Wow, big turnout, 11 today. The best I've had so far. It's a nice day, everyone who wants to get out, so they actually come in rather than stay at home and do it online. Just wait a few minutes and we'll get going. Anyone been to the show yet?
The Royal Show? No, not yet.
Went on the weekend. Wow, well, spent so much money. You don't get much out of it, but it's still a bit of fun. Kids loved it. Okay, I think we'll get underway. So this is the third lecture, which we're going to be talking on with regard to tissue repair and fibrosis. And this focus of this one is going to be on fibrosis and antifibrotic therapies. So just recapping, so this was the what you need to know slide. These three were the ones that sort of were pertinent to the last two lectures. And the next ones are the ones relevant to this one, although in saying that, they're pretty broad, so they cover all three anyway. But that is to review the major groups of soluble mediators, their activation, and roles in inflammation, repair, and fibrosis. To identify differences between tissue repair, regeneration, and fibrosis. And what processes are involved in fibrogenesis, so fibrosis. Describe key cells, profibrotic mediators, including TGF-beta. And describe current antifibrotic therapies and new approaches to treat fibrosis. Well, some ideas of some anyway. So just to recap what we talked about healing and repair. So healing was the restoration of damaged living tissues, organs and biological systems to normal function. And it's the process by which the cells in the body regenerate and repair to reduce the size of a damaged or necrotic area. So we talked about that. And then we compared that, we talked about regeneration was the growth of cells and tissues to replace lost structures. That it requires intact tissue scaffolds and it requires appropriate stem cells to be intact. Whereas healing was the formation of scar tissue. You needed an extracellular matrix framework in place. You needed collagen, which acted as part of that framework. And then fibrosis was where you had the formation of excessive fibrous tissue. Can adversely affect functional capacity. For example, fibrosis following a myocardial infarct where you've got compromised contractile function. So with the heart, you can't get, cells don't repopulate, they don't divide, so instead you get scarring and fibrosis in that area. And then of course the heart can't contract properly. So that was, I mean, we're talking more fibrosis today, but that was sort of what we talked about a bit last week. And then, of course, fibrosis is an aberrant wound healing response. So it's wound healing gone wrong. So what is fibrosis? So, as I sort of just talked about, it's an excessive deposition of matrix components, results in the destruction of normal tissue, I think it's the architecture of it, and a compromise of the tissue function. Okay, so it depends often where that fibrosis is as to how it compromises function. And it can be a major clinical problem, again, depending on where it is. So clinical impacts then of excessive collagen deposition. So this is just going through a few of them. Post-operative adhesions. This is in the lining of your internal body organs and your body wall covered by what they call mesothelial cells. And when there's damage to them, sometimes what happens is the organs will stick to each other, or organ and body wall will stick to each other by these fibrous adhesions, which can cause bowel constriction, infertility in women, a whole pile of things, and can be very painful. Keloids is on the skin. It's when you get an outgrowth, so an excessive growth of cells in the skin, which keeps growing. And it's particularly genetically aligned, particularly some African countries and Asian countries. Caucasians can, in some cases, get them, but less common. Dupuytren's contracture, it's where you get the, in the hands in particular, you get a fibrosis of the ligaments, and such that they tighten, and then you can't straighten your hands. So you'll see people with fingers, for example, that are bent and they can't be straightened, and they've got to be operated on and released. Liver fibrosis. So here, all the blue is collagen. You should not see that in liver. You should have a very, very thin septum of collagen, and you can see that that's quite a lot of that in the liver. And of course, that's going to impact on liver function. Scleroderma, maybe not so clear from these pictures. Oh, it's not so bad from there. Effectively, it's fibrosis of the skin. This is on the hand. It can be any part of the body. Systemic sclerosis, which is a multi-organ fibrotic condition, which can affect the lungs in this case, where you can see the lungs are full of this white material, which is your collagen, and it can block up the lungs, but you can get it in various organs of the body. It's a systemic disease. Myocardial infarct, as I talked about before, it's for the fact that you can't get repopulation of the myocardial cells, so what happens is you get fibrosis instead, and then of course you can't get contraction. And now idiopathic pulmonary fibrosis we're going to talk a lot more about today, because that's what I work on, so of course I'm going to talk about what I work on, and my interest. And again, similar to systemic sclerosis, you can see those lungs there do not look normal. They're full of fibrotic tissue. And it's an idiopathic disease, so meaning we don't know what causes it. And CI-induced fibrosis, that's cochlear implant-induced fibrosis. So in the cochlea, a lot of people have implants these days. If you've got hearing problems, and you can get fibrosis, which impairs the function of that implant. And you can get that in as well. So they're just some examples. And here, just to show you, being a bit more topical, although I think everyone's sick and tired of COVID, but we were getting fibrosis in some patients in the lungs, and these were what people were dying of. So people that had COVID and had major respiratory problems is because they were ending up with a fibrosis in the lungs that was killing them. Okay, this though could be reversed, so they didn't always progress, but some people did or have progressed, and the question will be over the years to understand more about that and why, and whether we can stop it from progressing any further. But effectively, that's what happened. And you can just see here in these pictures, this here is the normal lung on the right, and on the left here, you can see here that lung is all full of, this is probably a bit of congestion, of inflammation, as well as fibrosis, and here fibrosis on the base of the lung down here. So wound healing and fibrosis, really they're very similar. So all it is one gone wrong. So with any wound healing, I mean this is just using an alveoli as the lung for an example, but it could be in a lot of different organs. Same sort of idea. Maybe different initial cells are affected. But in the lung, it's usually, in skin, etc., in this case, it's epithelial cell damage. You get damage, and it's repetitive damage. It doesn't just happen once, it keeps happening. You get inflammation, release of all these cytokines, chemokines, etc., which you would normally get in normal wound healing. But they keep getting made because you don't get repair of that epithelium. You then get the release of these pro-fibrotic mediators such as PDGF, TGF-beta, but they're normal wound healing factors as well. You need them there. Fibroblasts come in, they migrate in, they start proliferating. They then start differentiating into what we call a myofibroblast, which we talked about last week as well. These myofibroblasts are important for contraction. They also make a lot of the matrix. And so that's great. We need that in wound repair. But you want them to then stop once that resolves. Then they don't in fibrosis. It just keeps going. And they keep making more matrix. A lot of things like stretch can affect it. You get progenitor cells from the bone marrow can come in and keep adding more cells. You can get change so that epithelial cells, for example, are there, or blood vessel cells, endothelial cells, can undergo an EMT-like process, epithelial to mesenchymal transition, where they can become myofibroblast-like cells. So you get all these myofibroblasts collecting, making matrix, which is bad, and don't stop. And then you get an imbalance of your proteases, matrix metalloproteinases and their inhibitors, the TIMPs, the tumor inhibitors of metalloproteinases. There's an imbalance more towards the inhibitors. So if the inhibitors of metalloproteinases, of course the proteinases, what they do is they break down the matrix. So if there's more of the inhibitors of it, they don't break it down and it just keeps building up, building up. But normally you would have these here, just that they would be in balance. And then you get epithelial apoptosis. So cells keep dying, you don't get re-epithelialization in fibrosis, where you do in normal repair. So as you can see, that really wound healing and fibrosis follow very similar mechanisms. It's just the mechanisms to turn it off don't occur in fibrosis. So let's compare tissue repair and fibrosis. So on a normal repair and then fibrosis, we've got a single injury maybe with tissue repair, but you've got a repetitive injury with fibrosis. You've got acute inflammation which resolves in repair. In fibrosis, it leads to chronic inflammation, which is continuous. You get release of cytokines and growth factors. Well, you do in fibrosis as well. They just don't get turned off. You have innate and adaptive immune responses, and in both. But again, in fibrosis, something happens, they keep going. You get re-epithelialization in tissue repair. You get impaired re-epithelialization in fibrosis. You get normal fibroblast to myofibroblast differentiation, but then apoptosis of those myofibroblasts when they're not needed anymore. And they die or get cleared. Whereas in fibrosis, there are multiple different cell types which can turn into myofibroblasts, can differentiate, and then they senesce. And when they senesce, they don't die. They just sit there, they can't proliferate, but they churn out more matrix. One of the main reasons for fibrosis, we think. The MMPs, so these proteases and the inhibitors, are balanced in tissue repair. There's an imbalance in fibrosis, leading to more MMPs and less TIMPs. And in tissue repair, the extracellular matrix deposition is regulated, where it's unregulated in fibrosis, leading to excessive deposition. So there are common and distinct mechanisms in fibrosis. And if you think of the shared mechanisms, it's in the lower part here, in the red. So you've got, leukocyte infiltration, release of mediators. So you've got these Th2 T cell and macrophage M2. We talked about M2 macrophages. Cytokines released by these cells, and these cause more polarization to a Th2 M2 phenotype than a Th1 M1 phenotype. You've got core pathways of fibrosis. I'm saying core pathways, we don't really fully understand all of them. There's so many pathways that are probably involved. Are they involved in every fibrotic condition? Maybe, maybe not. But, there's lots of different ones which we know are important. So TGF-beta we know is really important, the most potent pro-fibrotic mediator we know of. Wnt signaling pathway, hedgehog pathway, platelet-derived growth factor. All these signaling pathways are involved. Then you've got a whole range of other things that are listed here. Won't need to go into great details of them, but coagulation cascades, etc., we know are all involved. We know that the immune system is important. The myofibroblast differentiation into myofibroblasts are important. And then, of course, we have tissue stiffness. So fibrosis, imagine scars, hard and solid, and that leads to more fibrosis. So tissue stiffness is really important. Hypoxia, because we're not getting enough oxygen, and epigenetic modifications. So we have modifications to the RNA and DNA, which then leads to this production of ECM and self-sustaining activation loop. And then we have disease-specific mediators or mechanisms of fibrosis. And this will depend on what the actual trigger is. So the disease-specific triggers will be different depending on the tissue. The site of injury will change, the cells will be different, the composition of the infiltrate will be slightly different. Similar in general processes as underlined here, but slightly different depending on the organ. Fibrotic tissue remodeling. There's a whole range. These are all different cells that can be, or different tissues, the cells of which can then differentiate to myofibroblasts. And again, of course, it depends on what tissues are where as to the types of cells that can differentiate into myofibroblasts. So, you can see here that although there are some very site-specific mechanisms, the predominant mechanisms of fibrosis are very, very similar. So what about pulmonary fibrosis? And let's say I'm going to be talking a little bit more about pulmonary fibrosis and use it as a model. So pulmonary fibrosis is the end stage of a heterogeneous group of disorders. There's lots of different types of pulmonary fibrotic conditions, characterized by the excessive deposition of extracellular matrix within the pulmonary interstitium. So it's not in the alveoli itself, it's in the interstitium around the alveoli, that result in the destruction of normal tissue architecture and a compromise in lung function. And you can imagine, if the lung gets filled with matrix and becomes stiff and hard, you're not going to be able to breathe. There's going to be reduced areas for oxygenation of the blood, and of course it's going to be a major impact on the patient's lung function. So what can cause pulmonary fibrosis? A whole range of things, and a lot of these can be, you can actually say, look at them in other organs as well. It can be drug-induced. A whole range of different drugs, chemotherapeutic agents, etc., can all lead to fibrosis. And one, I think we talked about bleomycin, which is used for maybe it was in the other class, but used as a chemotherapeutic agent for testicular cancer, is one of the most well-known causes of lung fibrosis, although it is reversible. Radiation, someone who has radiation treatment to the chest, breast cancer for example, can often end up with fibrosis of the lungs. Environmental issues, mold, animals, all different triggers, exposure to animal dander and all that sort of stuff can cause fibrosis, particularly if they've got a hypersensitivity condition and they end up with hypersensitivity pneumonitis. Autoimmune diseases, joint inflammation, skin changes, all these things can come from autoimmune diseases, and one of which is lung fibrosis. And then occupationally, really important. So we know that fibers such as asbestos, silica, really in the newspapers at the moment, a lot of this. So when you work on stone bench tops, particularly man-made stone bench tops, all that silica dust that gets breathed in, it's causing a disease called silicosis, which is a form of fibrosis. And of course, asbestos is asbestosis. And then one that I particularly work on is idiopathic pulmonary fibrosis, and the word idiopathic meaning we have no idea, so we don't know the cause of it. So pulmonary fibrosis, as I said, there's a whole range of different diseases, interstitial lung diseases. This is in the interstitium, okay, in the linings of each of the alveoli sac. Idiopathic pulmonary fibrosis is probably the most well known of them. Asbestosis, caused by asbestos, collagen vascular disorders, sarcoid, acute respiratory distress syndrome. ARDS is a really interesting one. It's something that often people in car accidents get, and that is an induced response to the body to cause fibrosis in the lungs, and they don't really fully understand why. It's probably a cytokine. From an injury, you end up with a cytokine burst, end up with this fibrosis in the lung, and 50% of people with ARDS will die of that. The other 50% will recover, and the fibrosis will resolve. And it's still really unclear as to why that happens. Characteristics in pulmonary fibrosis include increased number of fibroblasts and myofibroblasts, pretty consistent across all fibrotic conditions, increased amount of remodeling, increased angiogenesis, a decrease in prostaglandin E2, and it's a reciprocal agreement. So when PGE2 goes up, transforming growth factor beta goes down. When PG2 goes down, TGF-beta goes up. And of course, increased collagen. And for IPF in particular, the prognosis is very poor. 50% 3-year survival, chronic use of steroids they've used in the past, don't work, have significant side effects, in fact are detrimental. That used to be the therapy. That's no more. And now the current treatments, they're quite limited, and we're going to talk about these. Two drugs, one's called pirfenidone and the other's called nintedanib. And this just shows you what normal lung should look like. So there's a histology of normal lung. You've got nice thin alveolar septa. You've got patent airways, so they're nice and open, good gas exchange. But in fibrosis, this all gets clogged up. This is IPF. This shows you all the matrix, all the collagen that's blocked up. You can imagine you're not going to get much gas exchange going on here. Okay? And this is a very patchy disease, so the whole lung doesn't become like that. There's patches of it, but of course it gets worse and worse over time to the point where eventually it kills the patient. So collagen deposition then is the hallmark of lung fibrosis, as it is the hallmark of any fibrotic condition. This is normal lung, and this is IPF lung. You can imagine you're not going to get such a good effect breathing, with IPF lung. There's a lot of fibrosis. All the white is fibrosis. You want to see dark. Dark is air. And so the white is the fibrotic areas, and there's holes as well. And there's this area around here, it's called honeycombing, which is a characteristic of IPF. And when you look at it from an ultrastructural point of view, this is normal at the top. You need this nice thin septa. So in fact, you've got epithelium, endothelium, endothelium, epithelium in this area with blood flowing through it. It's so thin. So here, that membrane here is both a mixture of epithelial and endothelial cells, and likewise there. Okay, nice and thin, and that's a red blood cell, so you can see how thin that septa is. And this is fibrosis. So there's some red blood cells, but you can see all full of collagen in the middle here, and that's thickened it up. So what about current IPF treatments? Well, nintedanib is a tyrosine kinase inhibitor. It targets things such as vascular endothelial growth factor receptor, FGF, so fibroblast growth factor, and platelet-derived growth factor, the receptors and on the molecules themselves. So it basically blocks signaling of these molecules. It slows the decrease in forced vital capacity. Now, forced vital capacity is the amount of air you can breathe out very, very quickly. So I don't know if anyone's got asthma here and have gone and seen your GP and they get you to breathe into a tube, and you have to blow everything out really, really quickly. And what it does, it measures the amount of air that you can, in a short period of time, blow out. And of course, if you've got impaired lung function, one is you can't blow out a lot of air very quickly, and also it just slowly leaks out. You're sort of struggling to get the air out. And so it's a sign of lung function. And in patients taking nintedanib, some of them, not all of them, show a decrease, a slowdown in the decrease in this FEV1, they call it. But as I said, it's for some. It's only a small proportion of patients that significantly benefit from this. Causes increase in quality of life, though, for some people, because it slows down their fibrosis. But it's approximately $55,000 a year to take it. It's now come on the PBS, which is good for some people, but it's really expensive. Has nasty side effects. We'll talk about that a little bit later on. So that's nintedanib. I think it's better than pirfenidone, but most people actually take pirfenidone. It's the drug of choice. I don't know why, probably marketing, but anyway. It's anti-fibrotic, anti-inflammatory, targets fibroblast proliferation, and it's thought to work by blocking TGF-beta-induced collagen production. I said thought to be through that mechanism, which is interesting because the guidelines from the actual company that makes it says that the mechanism is unknown, and yet everybody tells you it works through TGF-beta inhibition. Again, it slows the FEV1, slows the decrease in FEV1 for some people, just like it does for nintedanib. They suggest there's progression-free survival, so people live longer. And it depends which paper you read. Maybe some, maybe a bit, but it's not very clear. Again, some people it increases the quality of life. This time it's approximately $70,000 per year for this drug, and very, very nasty side effects once again. So clearly there's a need for more effective IPF treatments. And these treatments are also being tried in other fibrotic conditions because some of them can be treated with steroids, some of them can be treated with anti-inflammatories, depending on the progress of the disease. But if they're continuous fibrosis that can't be halted, then none of those work, in which case they're now trying nintedanib and pirfenidone in those as well. So how does nintedanib actually work? Well, as I mentioned before, it works by blocking the signaling pathways. So here, the FGF receptor, PDGF receptor, VGF receptor. You don't have to remember all this, other than to know that what it does is it blocks at various levels. It can block those receptors. It blocks the tyrosine kinases, in which case you then affect your downstream, and so it blocks the fibrosis that results from it, the fibroblast to myofibroblast differentiation, for example, and the collagen production. But this is mainly, I suppose, the other thing too is it's nintedanib's main activity is blocking growth factors, so blocking proliferation, blocking increased vascular growth, things like that. And just to remind you, we're going to go through this in detail, but this transforming growth factor beta, which was the last thing we talked about, very important for the next drug, pirfenidone. And the key here is that it's pro-fibrotic and increases matrix synthesis, increases differentiation to myofibroblasts. It slows down the degradation of matrix and increases survival of myofibroblasts. So this is a really important growth factor. And what pirfenidone is thought to do is it's supposed to work by blocking SMAD2/3, which is a signaling pathway for TGF-beta, at least the canonical signaling pathway for TGF-beta, because there are a lot of other signaling pathways that also work through TGF-beta. And then the downstream is to have the effects, as I said, on fibroblast differentiation of myofibroblasts, collagen production, etc. But, and I said here, or, people have also suggested, oh no, it also does these other things. Not only does it affect TGF-beta directly, but it might affect PDGF, it might affect FGF, it might affect antioxidant production, it might affect cytokines released by T cells and macrophages, it may affect dendritic cells. So in other words, they have no idea what it really does. The key here is I don't expect you to know all this, and you would use the line of, pirfenidone, it's unclear of the mechanism, but it's thought to work through blocking TGF-beta, because that's the standard. However, it's not as clear-cut as that. And I'll show you an example of why that's the case. So this is just showing you TGF-beta receptor. This is canonical SMAD pathway. These are some of the other non-canonical pathways which are activated by TGF-beta. Now, you would have all done Western blots, I think, in part of your course. You probably look for a particular protein, so Western blots look at measuring protein. If you want to look at signaling pathways, what you look is at phosphorylation of proteins, not just whether they're there or not. And the key with the SMAD pathway is you want to see phosphorylation of SMAD3. So if you just look at this top blot here, if we stimulate a cell with TGF-beta, we get an increase in phospho-SMAD3. In this case, they're not stimulated, and there's nothing there, and these are treated with pirfenidone, but there's nothing there, so they haven't been upregulated, so you wouldn't expect to see anything. But when we treat cells with TGF-beta and block with 1.5 or 0.1 milligrams per mil of pirfenidone, we get no reduction in phospho-SMAD3. This is work from our lab, but others have done it as well. So it's supposed to work through blocking SMAD3. Well, it doesn't in this case. Is it cell type specific? Well, maybe, don't know. But in this case, if you look at a phospho-AKT, we do have a reduction, and that's so the lowest concentration going up of AKT, phospho-AKT. So maybe in this case, it's working through the PHAR3320 kinase AKT pathway. It's just so unclear. Again, the key here is don't always believe what you hear. And what happens is people come out with things and say all these things and everyone believes it, and then as time goes on you find that that's not the case. So pirfenidone and nintedanib then is very expensive, has severe side effects in many, if not most patients. Pirfenidone, you can have headaches, dizziness, insomnia, loss of appetite, weight loss, upper respiratory tract infections. Well, if you've got lung problems, that's the last thing you want. Sinus inflammation and tiredness. Nintedanib, which is a better drug, I think, however, in some patients causes nausea, abdominal pain, and abnormal liver function tests. So it tends to be not the drug of choice. The mechanisms are unclear, particularly with pirfenidone, and it's not effective in all patients. Improved survival, limited. But the thing is, it's still the best we've got, and it probably will be for some time. So let's look now into the future of where we might be going with antifibrotic therapy. Well, maybe we won't even need lungs in the future. Maybe these bionic lungs that are being developed. So we won't have to worry about any drugs or anything like that. Maybe we won't have to worry about people because we'll just all be robots. Maybe we'll end up looking like this. I hope not. Maybe we'll look like this. Now, this shows age. How many of you can remember Steve Austin, the $6 Million Man, or ever seen any of the old programs? I bet nobody here. So this was in the 70s, and he was the first bionic man. And he was worth $6 million. Well, imagine that. I think you'd be lucky to get a reasonable house in Peppy Grove for $6 million. It'd be $6 billion man now. But of course, he could leap tall buildings and all that sort of stuff. Or maybe we'll end up looking something like this. And I think you're a bit more familiar with this. And we do not want to go down this road, of course. Whoops. So what can we do to block the pathogenesis of IPF? Well, maybe we should tackle this. These are some of the signaling pathways. In fact, this is not all signaling pathways. This is just metabolism. You can see how complicated everything is. Pathways after pathways linking into each other, affecting each other. It's a tough gig to try and solve the problem. And people will do it eventually. But we don't fully understand how things interact. And until we do, we're not going to fully understand the best ways of stopping certain diseases. So what do we do when we do science these days? Well, a lot of people do what I call refrigerator science. And that is, they literally go to the refrigerator, this is what drug companies do for clinical trials, see what's in the fridge, in the fridge, and take out and then stick it into somebody, particularly with certain drugs. So these days, pirfenidone. They take pirfenidone, they think, oh, it doesn't work that well. Let's go to the fridge, see what drugs we've got there, let's combine it with pirfenidone and see what happens. Not good science. So this is it. This is, we go to the fridge, see what's there, we'll try it out. What happens then is we become beholden to that refrigerator or to the drug companies that we just do their bidding. And there's a lot of people that do that. A lot of clinical science is done just testing drugs with no really basis behind them at all. You need to have the science behind it. And often they don't have any science behind it. In fact, a lot of times you see combined drugs and you think that's going to be detrimental, and it usually is. And if we don't have some basic science, this is a plug here on basic science, if we don't do discovery basic science, we're going to eventually go to the fridge and there's going to be nothing there worth actually trying anymore. So we need to have basic science leading to clinical science. So what about then, what are some of the drugs being trialed? So this is a general pathogenesis of IPF slide. So we've got injury to the epithelial cells, release of inflammatory mediators, endothelial cells can differentiate, etc. They can also release coagulation cascade proteins can come from the blood. You get inflammatory cell migration. All these immune cells are really, really important. Cytokines are released from them, etc., including the ones we've talked about, TGF-beta, PDGF, VGF. Interleukin-6 is another really important one, which signals through the STAT pathway. And then this basically leads to fibroblast, myofibroblast differentiation, collagen production, etc., and we get fibrosis. Now these are all drugs which are currently in clinical trial for IPF. And a lot of these drugs are also in clinical trial for other fibrotic conditions. And they attack all stages of the mechanistic pathway. Right from protecting the epithelium up here, to blocking the mediator, inflammatory mediator release, to affecting the endothelial cells, because we think endothelium is really important, and therefore if we protect the endothelium we can improve or prevent fibrosis. Stem cells are important. If we can improve and reactivate stem cells, we might get normal repair, and we don't get this problem of lack of reepithelialization. Drugs that affect coagulation cascade. Rituximab, we'll mention a bit later on, but that's an antibody which basically blocks B cells. And there's also drugs that are out there looking at T cells as well, inhibiting T cell function. And then, of course, we've got pirfenidone, nintedanib. So other drugs that affect all these pro-inflammatory cytokines, pro-fibrotic cytokines. But we do need these drugs, remember, as well. So we need them, we need these mediators for normal repair. All comes down to the balance. And there's a whole range of other drugs as well, which are being tested at various levels to stop this EMT type response, this fibroblast to myofibroblast differentiation. So these are all drugs currently in clinical trial. And I can assure you that probably all of these drugs, if not 99% of them, will be ineffective. But we've got to try them. They work really well in animal models, they work really well in vitro, but don't necessarily work well in patients. And then in green here, these are drugs that are in preclinical development. So these are still in preclinical models. And these preclinical models are in vitro studies and usually animal studies. So these are even more ones that are coming up now. Ones that affect the RNA, for example, epigenetic regulation, so at various different levels. We've got STAT inhibitors, which are really important for blocking IL-6. We've got modulators of cellular senescence, which we're going to talk a little bit about in a moment. So there's a whole range of other drugs which are being developed, which aren't in clinical trial yet, but are soon to be in clinical trial. And you can imagine how much this is costing the drug companies to afford to actually fund these sort of trials. You can imagine that when they come out with a U-But drug that works, why they then charge so much money for that drug. Because it costs them absolutely millions, hundreds of millions, billions of dollars to try all these drugs that don't work. So these are just some drugs, and again, I don't want you to pay attention to this at all. It's just to show you that there's a whole range of drugs which are currently in trial for different fibrotic diseases. This is not just for IPF, this is for others as well. But what I wanted to point out here is the ones that are ringed, all those that are blocking TGF-beta. So we're still trying to block TGF-beta. Problem is in the past we've done a whole range of other drugs which block TGF-beta and they don't work. Not saying that TGF-beta is not important, but maybe it's too far downstream, or maybe it's too far upstream. We don't know why it's not working, but obviously other things can affect TGF-beta and these drugs don't do it. So blocking TGF-beta alone is not going to be the solution. But we still just keep blocking TGF-beta. So, we've got probably, 30% of them, a third of the drugs are all TGF-beta inhibitors. So I'm just going to talk about a couple of others that are a bit different that are being trialed. So these are literally in the development stage that are just going to go into clinical trial. One of them is called a senolytic. And these are a class of small molecules. And what they do is they selectively induce the death of senescent cells. And a senescent cell is a cell that can no longer divide. So as I mentioned before, myofibroblasts are like that. Well, they are in fibrosis. They're not in normal wound repair, because when they're not needed in normal wound repair, they apoptose and then they're cleared by macrophages, etc., which get rid of them. But in fibrosis, they go into senescence and they sit there. And the normal mechanisms of clearing them doesn't work. So these cells just sit there and churn out all their goodies and make lots of matrix, and they're just a production line. So these senolytics, they prevent, alleviate, or reverse what they call age-related diseases, because this is an age-related phenomenon. Okay. So the older you get, the more your cells go into senescence. And what it does is they eliminate the senescent cells, either pharmacologically or genetically. And so studies have been done in mice to prove that you can get rid of fibrosis and improve lung function using these senolytic drugs. But that's great in mice. It doesn't always work in humans. But they're being trialled in a lot of different disease settings at the moment. So what happens with cellular senescence? So you've got maybe epithelial cell, fibroblast, endothelial senescence can occur. These all occur at some point. But then you get, normal senescence. You have telomere shortening, which leads to senescence. Oxidative stresses all can lead to senescence. So these are all inducers of senescence: epigenetic modification, mitochondrial dysfunction, oncogene activation, etc. And what would normally happen is that these cells would senesce and then be cleared. But in the case of chronic diseases like fibrosis, you get stem cell exhaustion. The cells are no longer there to replenish the other cells that are damaged and need normal replacement. You get myofibroblast resistance to apoptosis, as I mentioned before. These myofibroblasts just hang around. You get an increase in, this is secretory, I've forgotten the name of it now, SASP, secretory associated senescence-associated secretory protein. That's it. Senescence-associated secretory protein. And what these are is really a load of cytokines. So it's a whole range of cytokines which are there to promote inflammation, and they actually promote cellular senescence as well. So this is just like a milieu which keeps going on. And all of these lead to is a decline in the tissue regeneration capacity, an increase in aging and age-related diseases, which is what we get in IPF. So these are the two probably the most well-known of the senolytic drugs, dasatinib and quercetin. Dasatinib is a tyrosine kinase inhibitor that targets the B cell receptor, ABL, and SRC, etc., and other tyrosine kinases as well. It's used as an anti-cancer drug for certain leukemias. Quercetin, on the other hand, is a plant flavor used in dietary supplements. It's an antioxidant, inhibits the PI3 kinase AKT pathway, reduces the anti-apoptotic BCL. So BCL is anti-apoptotic, so what you want to do is get rid of that, and so it reduces that. And it's also a non-specific phosphate protein kinase inhibitor. It's anti-inflammatory and it's anti-cancer. And interestingly, it's often used in combination. And they work on their own to some degree, but they work really well together. And there's been a number of clinical trials being tried with these senolytics with regard to fibrosis. So with the first trial, 14 IPF patients, all of them were given the combination of this drug, and it improved some of their clinical measures, but it was not shown to increase pulmonary function or any of the clinical chemistries. But this was all done in a very short period of time, so maybe we'd have to take it a bit longer. But this was sort of really positive, and so it led on to a second trial. And in the second trial, we did 12 patients, but this time we used both test and placebo. However, it showed no impact on lung function in IPF patients whatsoever. So you've got to be careful not to throw the baby out with the bathwater, because in this case, maybe these aren't the best drugs for IPF. But this is a whole range of new senolytic drugs which are yet to be tested. And so, we've got, and I'm sure there'll be a lot more developed since after this, because we really think, we do know that aging-related disease is all about senescence, cellular senescence. So if we can overcome that, well, we also can, stay young for much longer, if that's the idea maybe. But as far as disease goes, we can get rid of a lot of these chronic diseases if we can overcome this. What about immunotherapy? So this is recombinant human monoclonal antibodies, which are used to a whole range of things. So we can block basically all these mediators by putting antibodies out to them. And of course, there's our old favourite, one that's being tested for TGF-beta 1 to 3. There's ones being tested for other key mediators, for example, connective tissue growth factor, CTGF, which is another potent profibrotic mediator, probably downstream of TGF-beta. Alpha V beta 6, that's an integrin. These are molecules which bind, that are receptors on the surface of cells that bind to matrix, etc. And that is one that's known to activate TGF-beta. So again, we're still on the TGF-beta pathway. Interleukin 13 is thought to be really important, particularly in things like asthma, but now it's been looked at in fibrosis. So there's all these different antibodies which are out there that are being used to try and target key mediators of the fibrotic response. And then there's, of course, immunotherapy. So we know that IPF is a heterogeneous disease characterized by an aberrantly activated immune system. And now, this is an interesting one, and that is a lot of people still don't see the immune system as being important in fibrosis. But there's more and more papers coming out. So this is sort of new cutting-edge type stuff to show that the immune system is really important, and it's aberrantly activated in the case of fibrosis. So, and we know that T cells, of course, are really, really important in fibrosis. And we've got our T cells, and what we do know is that a number of these T cells, particularly Th17 cells, are closely associated with fibrosis. And so, we've got here Th17 leads to extracellular matrix production. You've got Th2 cells, which are important for fibroblast proliferation and differentiation of myofibroblasts. And then we've got a problem with T regulatory cells that can't control the T cell milieu. Then that can also lead to fibrosis. So we know that T cells are important. And there's a great little review called T cells in idiopathic pulmonary fibrosis, crucial but controversial, which just highlights the fact that I'm saying that people still really don't fully understand the importance of the immune system in fibrosis. But what they are doing now is they're starting to do T-cell therapies. So we're starting to use checkpoint inhibitors. You would have learnt probably from last year's lectures you may have done, or maybe even this year. Checkpoint inhibitors are used in cancer to basically block the interaction between the cancer cell and the T cell. By blocking that interaction, these molecules, what they do is they send the immune system to sleep when they're combined. And so if you block that, you reawaken the immune system and it can be activated again. And we're finding that these checkpoint inhibitors actually, in experimental models, can actually prevent fibrosis as well. Maybe by affecting the interaction directly with the myofibroblasts. The mechanism is still being worked out. There's actually one that's in clinical trial at the moment, which is an anti-PD-L1 inhibitor. Anti-PD-L1 inhibitor. There is vaccines to ADAM12. ADAM12 is a matrix metalloproteinase, and it's thought to be important in the differentiation of myofibroblasts, and so that's being tested as a vaccine. An interesting approach. CAR T cells are being used, and these are T cells which are engineered to specifically target a cell. It's also engineered so it's really activated. So it targets a cell, it's activated, and it kills it. And so this is being used to a protein called FAP, or fibroblast activating factor. And so this is currently being trialed. So there's lots of these things that are being tested now at the moment. And then, of course, you've got B-cell therapies. I mentioned before, there's one called rituximab. It's a monoclonal antibody that targets CD20, which is a protein on the surface of B cells, but it's only on the surface of mature B cells. And it's been shown to improve or rescue patients with a progressive interstitial lung disease, which is non-IPF, so it's called systemic sclerosis. And this disease, it slows down the exacerbation. So some people get an exacerbation of it, and it gets really, really bad, and then it sort of settles down and gets worse again. And it can slow down that exacerbation. And as I said, it's also been shown in IPF patients with acute exacerbations to actually show some lung improvement. However, it's also been shown to induce acute lung injury as well. So, you've got good on one side and bad on the other. The problem that we think with this is that it only attacks mature B cells. And some of our own research, which we've recently published, has shown that it's actually the antibody producing cell, the plasma cell, which may be more important and maybe should be the one that should be removed. And so we're actually doing some research now trying to specifically remove plasma cells. So that's really just giving you an overview of some of the, of fibrosis and some of the drugs that are being currently used. And there's a long way to go. We've only got 2 drugs really that treat fibrosis properly at the moment, particularly in the lung, but in a lot of other tissues as well. And there's a lot of money out there to be made if you get antifibrotic drugs, because scarring is a big issue. And if you can get anti-scarring drugs, etc., there's a lot of money to be made. So anyone got any question, please feel free to come and ask me afterwards or now, or whatever. Thanks, Sam. No worries. Yeah.
I had a question from the clinical pharmacology lectures. With the calculating the loading dose, here you gave an example of milligrams per
Yep.
minutes per dose. Is that assuming that 1 kilogram?
So that at 80 kilogram person, so you multiply 80 by 10, and that gives you, but it's 10 milligram, so that's the concentration of gentamicin, so that's needed down here, okay, at 10 milligram. You first of all got to get your velocity distribution, okay, and so that is your 80, the weight, times by what's given to you, which is given to you as, what has it got, 0.8, oh, there, average, VD of gentamicin is 0.8, so you do your 0.8 multiplied by the weight, because it's per kilogram, and that gives you your volume distribution. and then you do your dose is multiplied by what you expect, you want it to be final dose, which is 10 mgs, because that's what the dose is you want to get, okay? So you multiply that by your volume
Sorry, so the
distribution.
kilogram and the liters, it's,
Okay, they chop each other out, because if you think about it,
I can understand this one cancelling and
Yep.
then you get the L, but
Yep.
I don't get how that one turns to
because per litre, it's over L,
off
okay? Because that's, your kilograms is gone now,
from.
okay? So it's milligram per kilogram, and that's, so let's look, milligrams per litre. So your CI is that over your total litres, that gets rid of that in milligrams. Yeah, because this is the, so it's in terms of milligram. A kilogram's gone, because you've already got rid of your per kilogram, because that is already taken into consideration kilograms. So it's no longer, the weight of the person is no longer involved with it. We're talking about the total volume that's going into that patient. Sorry, the total mass of the drug that's going into that patient. So you've not got, kilograms have gone. They've already been removed, because that is per kilogram. So it's kilogram over kilogram. It's gone. Shoot. So that is milligrams per. So per kilogram should be really, I suppose, it could be said as milligram per volume of distribution, which is your 64L. I know where you're coming from, but yeah, well, how would you say it, I suppose? Yeah, good question. The kilograms is gone, because we're not talking in kilograms anymore.
I mean, I understand for the kilogram getting cancelled for the
Yeah.
volume, but for the blood concentration,
Yeah, but it's still, so because you're right, it doesn't cross out that way, but it doesn't get thought that way, because it's no longer, you're not worried about per kilogram. You've converted your kilograms into a volume, yeah.
distribution.
And so volume of distribution, it does not come in kilograms. So that is already taken into consideration. That I know where you're coming from, because it doesn't cancel out, but it doesn't matter anymore, because you're not talking about per kilogram. It's already been taken into consideration when you've worked out that original volume.
Okay.
So
So this one kind of just automatically changes to L.
well, it doesn't automatically change. It is per litre, okay? Because you've got litres in there, so it's now milligram per litre. That kilogram has been turned into a volume.
So the kilogram always turns to volume. So even
Well,
if it
in
was
terms of this,
yeah.
because you've converted it from kilograms to a volume equivalent, which is your volume of distribution. I know what you mean. Where's the kg gone? But you've sort of already got rid of that in your original calculation of volume of distribution.
Okay.
Yeah, but I know where you're coming from. I can see your point.
Thank you.
So that's just curious. When you mentioned the clinical trials, like some of the drugs work really well in animals, but then when it got to humans, they didn't work well. Is there a reason?
Well, often a whole pile of reasons. One is we're not the same as the mouse, although a lot of these studies are done in mouse. But also the models that are used are not the same. So there is no model, for example, IPF. There is no model of animal IPF. Well, there may be a cat that might do it naturally, but because of that, we have to induce fibrosis in an animal model, and we use drugs to induce it, but it's not the same. So we can cure that type of disease in a mouse because we've created it. So we create the type, we can solve that sort of disease, but it's not the same as human IPF. So what we're doing